Hi, everyone. We're going to get started here. I just want to remind folks this is being recorded and it'll be available online down the road. But I'm Corinne Lewis. I'm the Assistant Vice President for Delivery System Reform at the Commonwealth Fund. I want to start by thanking AAFP and Primary Care for America for planning this event and for having us as a partner. And thank you, of course, to the experts and speakers that have traveled to be here today for this important conversation. So for those of you that are not familiar with the fund, we are a national, nonpartisan foundation dedicated to affordable and quality healthcare for everyone. We support independent research on healthcare issues and make grants to improve healthcare practice and policy. We have a long history as an organization of working to strengthen primary care. We really do see it as the foundation of a high-performing healthcare system and as really important for addressing our biggest challenges in healthcare, from increasing chronic disease, growing health disparities, and the behavioral health crisis. Building off of the 2020 NASEM report on implementing high-quality primary care, we, over the last several years, have been focusing our efforts on payment reform for primary care. And that includes both changing how we pay, so moving from fee-for-service to hybrid approaches, as well as changing how much we pay, so increasing investment. We're here today to talk about the latter, increasing investment. Despite robust evidence that links primary care to improved health outcomes, we invest just 5 cents of every healthcare dollar on it. And in Medicare, studies find it's actually even less, just 3% of spending, despite, of course, the greater needs of the Medicare population for care coordination and management of chronic conditions. A core cause of this underinvestment in critical primary care services is the process by which we set rates in Medicare, so the resource-based relative value scale and the RVU Update Committee, or the RUC, which you will hear more about later today. Experts have long suggested that these systems have disadvantaged primary care, negatively affecting reimbursement in Medicare and beyond, and ultimately contributing to the largest problems we see in primary care, including dwindling supply of providers and limiting access to high-quality care for patients. There is growing interest among policymakers in identifying new processes for valuing clinician services, in part to support primary care, and that's what we're going to be talking about today. So I'm really looking forward to this timely discussion and to hearing the ideas on how we can better value primary care. Thank you so much again for being here, and I will now turn it over to Dr. Asaf Bitton, the Executive Director at Ariadne Labs, and a practicing primary care physician himself, to share more about the history of primary care payment and how we can improve. Thank you.
Thanks so much, Corinne. It's really a pleasure to be here today with you all. I'm going to spend the next 20 or so minutes giving a discussion to try to ground us on the same page around how the primary system for paying primary care came to be, and sort of having a kind of common narrative or common history of it. And then the speakers on the panel will discuss sort of the finer points, the areas of disagreement, the areas of sort of policy potential moving forward. I do have to declare that I'm speaking on as a primary care physician and faculty member at Harvard School of Public Health. I'm not speaking in my other role, which is as a senior advisor to CMMI. So these points of view only reflect my own. So I think it's helpful to think about the fact that actually physician fee schedules have been around for more than 140 years. This is an actual book that I found at an antiquarian book fair. It's a fascinating book it's called The Physician as a Businessman by Dr. J.J. Taylor. And he, in 1892, went all around the country and he collected fee schedules. Basically, you can imagine this as sort of fee-for-service of the 19th century. What were doctors charging for visits and for procedures? A couple of interesting observations about this funny little book. Number one, the same kind of disparities in pay that you see between proceduralists and generalists were here as well. So you got paid a lot more to do a simple or not so simple procedure, bone setting after you break a bone, lancing a boil, than you did to do a visit, often 3 to 5x. Second interesting observation is that there's risk adjustment. It's a little bit different, but you got paid $3 for a visit at night, $2 for a visit during the day, and $4 or $5 if the patient had consumption, otherwise known as tuberculosis. So a little bit of risk adjustment. Remember, most of these visits happened at people's homes with this sort of requisite black bag. So just a sort of level set that we've had physician fee schedules in the US, and they were collected from all over the country for many, many years. And sort of over the beginnings of the 20th century, these fee schedules were adjusted and had their own sort of local flavor. But really, even at and through the beginning of Medicare and the expansion of commercial health insurance mechanisms in the 60s and 70s, most physician payment was to the a term, usual and customary fees. And that became a challenge by the 1980s, really the late 70s, when the cost of providing care continued to get higher, matched with the technological expansions, and we could do more as a healthcare community with and for patients, and that was usually great, but it started to cost more and more, especially if the people doing more could charge usual and customary fees. And so what happened was that a group of health economists came together in the 1980s, led by Bill Shao, who was on faculty at Harvard School of Public Health, and with the intention and with some funding from a variety of sources to really try to codify what it took to provide physician level care, what it took to provide comparable levels of care across different environments. And so they published their results after sort of doing time and motion studies and following hundreds of doctors and doctor visits around in a famous set of JAMA papers in the mid-80s, again with the aim to try to create resource-based relative values, comparable values for the same work, and for the work of measuring physician effort across very different specialties, from proceduralist to generalist, comprehensive care to sort of very specific care. And then along comes something called OBRA, which is the Omnibus Budget Reconciliation Act of 1989. And really within this act, and if you care about the details, this is really worth taking a look at some of the history. I know a few people in the room are quite familiar with this history. Really what is encoded in this Budget Reconciliation Act is an attempt by Congress at the time to rein in and get a handle on and codify and make relative in a comparable manner very different expanding physician fee schedules and physician prices for their services. And so a new payment system was codified. And actually the Act tasks CMS with codifying a payment system for physician work. And yes, it was labeled as physician, though of course we know that many health professionals are critical in the work. By definition in the Act, it was labeled as a physician fee schedule that would quantify the relative value of physician work using this relative value scale that Bill Shao and others had created, and would sort of codify the way that this comparable schedule was composed of in 3 areas. It would look at the value of clinical work, and we'll decompose what we mean by clinical work. So clinical work as at least half. About 45% would be a way to sort of codify and make comparable practice expenses at the geographic and different practice arrangement area. And then a small amount, but making sure to sort of codify a professional liability insurance. And it's the combination of those 3 areas that would inform the creation of the physician fee schedule that was mandated by OBRA 1989. So again, I'm trying to build up to a history, hopefully useful for you, of we often go straight to the RUC or straight to fee-for-service, but there's a whole, keep that well built there. There's a whole history that's mandated by law around how we've come to where we are. So let's go a layer deeper. So the Medicare Physician Schedule fee schedule is located in Part B of Medicare, and it's nearly $100 billion a year, so it's a huge outlay. The vast majority of fees are for single services, unit services, but there are important care bundles, especially in surgical areas, and actually we'll talk about an important care bundle that's new for non-surgical areas. As it is part of Part B, it is subject to Part B provisions. It's written in the original Medicare statute, which is 80%, 20%. So Medicare pays 80%, the individual, or if they have coinsurance, so if they have traditional Medicare, they are on the hook for the 20% coinsurance unless they have a separate Medigap plan. If they're in Medicare Advantage, different sort of rules apply for another day. Or we can talk about it in the panel. This last provision is critical. Any updates or changes to the Medicare Physician Fee Schedule by statute above $20 million, which is a lot of money, but in this fee schedule that's $100 billion, it's less than a lot of money. Any changes above that, if you change it year over year, have to be budget neutral to other parts of the fee schedule. So keep this, some people call this the relativity. This is not Einstein's theory of relativity. We're not in physics. We are in American healthcare payment. And that relativity means that you can't just say, we want to pay more for this stuff without paying less or finding a way to pay for less or adjusting for less. And so you have these codes, mostly level 1 CPT codes, some level 2, which are sort of these bundles, and together they form HCPCS, this Healthcare Common Procedural Coding System, which really has defined since the early 90s modern American fee-for-service payment, which is the dominant payment. Even if you add an overlay of value-based care, it's still the dominant codification, quantification of payment in the US. And the reason it is because it aligns with statute. The statute says that the fee schedule has to have a codified comparable way, that there needs to be a relative value of services that can be measured across disparate services. So you have to be able to measure the value of an ophthalmologist's care as well as a primary care physician's care, and as well as the people who work with and around those people. And that value, remember, it's work, practice expenses, and liability. The value of work, these are the components of work. This is from the AMA here, but it well captures what are the components of work according to the fee schedule, not according to what you want it to be, or maybe you have a problem with that, but this is what it says. Work is the technical skill and physician effort, or physical effort to do something, the time to perform something, the mental effort and judgment to do it, and stress around it. That's how work is defined. Note that the relative values of services or work does not include and is not based on the necessity of service. Should this happen? Is it appropriate? The quality of the service, did it happen in a way that is conducive or to patient care, to good patient care, to quality? No, it has no assessment of quality outcomes, no tie to quality outcomes, nor is it at all related to the health and population health outcomes of the service. It is related to these 4 areas. And as such, in statute, now we get to the RUC, but in statute, there needs to be a way to encode relative values of very different services, to compare them, to accept information about them and that information has to include some form of empirical studies, submitted through and with physician input, through proper guidelines and statute. So those three areas of requirements are why the RUC came to be. Now the RUC is the Relative Value Scale Update Committee, so some V and S's dropped off that, so it's the RUC. And what it attempts to do is offer outside of Medicare an opportunity for a fee schedule and comparison of values and really complex areas of payment to be sat in, and their representatives, AMA convenes this committee, their representatives from all the major specialties. 22 are appointed by the specialty societies. Of those, 4 represent primary care affiliated societies, and then there are a variety of other stakeholders that represent on the RUC. It is a non-governmental body. It meets under the auspices of the AMA, and we have representation of leadership from the RUC to talk more about it. But I'm trying to sort of present the reason that the RUC exists is because there needs to be a process by which CMS can accept and look at relative values of codes, and the relevant specialty societies through the RUC submit empirical information. Remember, requirement number 1 is that you have to submit empirically driven information about the work, and work is intensity, stress, time, and effort, right? It's not anything else we might wish it to be. And so they go through the process and they submit to CMS a set of recommendations on codes, and it needs, oops, sorry about the formatting here, you need a 2/3 majority, and then any relative value with at least 2/3 majority is passed on to CMS as a recommendation, always cognizant of budget neutrality. And then the CM, Center for Medicare, reviews the recommendations and historically has approved a very, very high proportion of them, almost 90%. Some years it's been as high as 95%. So the effects of the RUC reach far beyond the fee schedule for traditional Medicare alone, because Medicare Advantage, Medicaid managed care, most commercial insurers use the fee schedule to determine their fees as well. Now, that's the sort of facts of the process. There are concerns, and we're going to get into the concerns. Corinne talked about some of them. There are experts here who have written books and will speak to you about some of their concerns that they've documented with the process. There are concerns around distortions in time and intensity valuations of the work, both in how the data is collected. They're collected from society-driven surveys to their physician members who sometimes have a good response rate and sometimes have a very low response rate. And mostly it's self-reported effort and time spent on the work that physician group does. So you can imagine there might be an impulse for people to say that they work really hard, and they do. But if I asked you how hard did you work last week, you probably would say you worked pretty hard. So there's a question on the sort of distance or sort of ability to empirically judge effort in a completely comparable way. There's a bias in the fee schedule toward procedures and expensive therapeutics over relational care that requires coordination of care outside of a visit setting or complex diagnostic cascades that might take weeks or months. There's a specialty primary care imbalance on the committee, and there's some data concerns, especially around the surveys and how they pool data together. So the policy challenges, and some again that you'll hear in the audience come up with it. Some have called this this process as having the potential for regulatory capture, where sort of self-interest, and I don't define self-interest in known maliciousness, but self-interest in you have an autonomous professional regulation of its own mechanism of funding, and there can be almost no help but be self-interest involved in that, in addition to other interests. There's incomplete transparency on, a lot of people think that they know a lot about the RUC, but don't know really about all the components. Some people have described it as being difficult to get details of the RUC, though I do understand that AMA and the RUC does make their proceedings open and tries to sort of publish on it. There are major challenges paying for teams to care for communities and individuals as opposed to doctors to deliver procedural services. So there's an imbalance there. And essentially what this results, as Corinne said, in most of the primary care scholarship, basically all of it, if you look at the National Academy's report from 2021, is whether by intention or not, it is resulted in an insufficient form, level, and flow of money to primary care to do the work that primary care is asked and needs to do for the health of communities and individuals. So that's a pretty evidence-based contention. It may be uncomfortable to talk about, but it's pretty clear. And that's because primary care is facing a broken production model where, the RVUs that the physician fee schedule encodes have really not, until very recently, changed very much for the prime way that primary care does its business, which is visits. And that visit-based production model doesn't really conform to team-based, technology-enabled, population and individual-oriented primary care that is needed to integrate and care for promotive, preventive, chronic, palliative, rehabilitative care that communities need. The issue really is a distribution of money issue. Primary care sees in volume about 1/3 of visits, but gets, as Corinne said, about 5% of total payment. You can see for other parts of the healthcare system what those visit counts are, and of course there are things, drugs, procedures, other parts that are not counted here. So there's a visit remuneration discord here that relates to why people don't go into primary care and why people leave primary care and why there aren't enough primary care clinicians of all types to care for the communities who want that care. The math is pretty clear. This is not a polemic, just yay primary care and pay us more. This is math. This is a math paper in a primary care journal that basically says any way you look at it, you run a microsimulation model 10,000 times, there's really not a way to pay for what we term as the basics, the minimum of advanced team-based primary care using existing fee-for-service, even boosting it up 10%, even adding, what at the time were existing care management codes of $5 to $10 per person per month. You can't mathematically make the books work. So what you do is you say you're doing advanced primary care, but you're not really. You say you have a team, but you don't really pay for it. Or I don't want to suggest the other alternatives because I'm not sure of their legality. So that's the problem that primary care faces. It's not a charity case. It's not as some of you have heard me say, it's not a fuzzy bunny to sort of say, oh, you're so cute and friendly in the corner, and here's another coin. It's just a money and empirical issue. There's not enough money to do the things that are on the book of business of primary care. You know those studies, 26.7 hours per day to do the things on the recommended guideline list of primary care. That's before you even see the urgent care patients and do conversations about serious illness and palliative care. So again, if you take nothing out of it, you've learned or you've solidified your already high existing knowledge on the history of the fee schedule and the RUC, and you see this not as a charity case or just another physician group looking to get a little more money. This is a math issue. The math issue suggests that prospective payment at a high threshold level is necessary. And the way forward is likely by transitioning from fee-for-service to hybrid payments that are at a sufficient level with sufficient flow to get to where they need to get to provide primary care with the resources it needs. And if you're in a risk-bearing contract, then you make sure that money gets where it needs to go. I want to end in my last 1 or 2 minutes with a report that's out just 2 weeks ago from the National Academies. We have some co-authors here, Alex, Chris, myself, some others, around sort of presenting this history of, and here's the QR code for it, of how we've come to value primary care the way it is in the fee schedule, and what should be done to change it. So recommendation 1 is that there's a broader range of data that can be incorporated into the fee schedule around this primary care specific pieces that comes from EHRs, time and motion studies, high quality surveys of work intensity, and that this analysis using time-driven activity-based costing or large language modeling can add to CMS's retinue of tools that it can use to value primary care in a different, better way. Number 2, the CMS can account for a fuller range of the value-enhancing primary care activities by taking into account the efforts of the interprofessional team and non-encounter-based work, bundling codes together, and being cognizant that primary care's value is not created in a 10-minute visit. Number 3, there's new and different parallel. So not saying the RUC has its part, but there may be different ways that a parallel structure can include input from additional technical expert bodies inside or outside of CMS in parallel. They can, again, submit this new studies, new information through physician societies in a statute-compliant way to allow CMS to really enhance its ability to pay for the primary care it wishes to pay for. And finally, CMS has bundled some of these codes together around a non-visit based payment into something called advanced primary care management. And that bundling is promising and offers a strong new route. It cannot be discipline specific, meaning it cannot be only for primary care. It's open to anyone who can accomplish the sort of functional aspects of this kind of comprehensive, coordinated, continuous care. And we recommend that CMS should take care to not rush to expand or change these payments, but really understand their uptake, how they're being used, where changes need to be made to them in order to improve primary care. So with that, I will stop, and I thank you for your time.